Greetings and welcome to Bloomberg New Economy Conversations, the series where we explore how businesses and governments around the world are responding to the coronavirus pandemic. Today's conversation, public health on life support, will dive into the world of public health, how it's holding up amid the COVID-19 onslaught, and how we can use the lessons of this pandemic to rebuild a better, more responsive, more inclusive global health system. As always, I'm joining you from rural New Hampshire, not the Bloomberg headquarters in New York City. And I'd like to welcome our global community of Bloomberg New Economy delegates who've attended the forum in Beijing and Singapore these past 2 years. We also welcome the thousands of viewers tuning in on social media and via the Bloomberg terminal. There will be opportunities throughout this conversation for real-time input from you, our audience. I encourage you to submit questions in the text box in the bottom right of your screen, and I'll invite you to vote in live polling in the top right of your screen. If at any point you encounter technical difficulties, a simple refresh of your browser should help get things back on track. So we've got a wonderful panel coming up a bit later that you'll want to stick around for, but I'd like to start our program today with a fire starter conversation that I recorded yesterday with the Commissioner of Health for New York City, Dr. Oxiris Barbot. New York has been the center, of course, of COVID-19, epicenter of COVID-19 in the United States. And just as the city has begun to get the coronavirus pandemic under control after months of lockdown, the all too familiar epidemic of racism has prompted thousands of New Yorkers to take to the streets to participate in the Black Lives Matter protests. I spoke to Dr. Barbot about the link between inequality, racism, and public health. Take a listen. Dr. Oxiris Barbot, thank you for joining us.
Thank you for having me.
First of all, congratulations. New York City has flattened the curve, or as Governor Cuomo put it, has bent the curve. Nevertheless, we're seeing pictures of New Yorkers right now partying in the streets of the East Village as though the coronavirus had gone away completely. Do you worry that this kind of complacency might create a second wave of infections?
You know, I absolutely worry. I can understand the impulse of wanting to be outdoors and reverting to quote unquote life pre-COVID, but the reality is that all of the measures that we put in place for social distancing, including the use of face coverings, are what were giving us the ability to really bend the curve. And so my fear is that we will squander that opportunity by having people not adhere to social distancing and the use of face covering. So yeah, we're taking every opportunity to remind New Yorkers we are nowhere out of the woods. We need people to keep using face coverings and to stay indoors as much as possible.
So Governor Cuomo has threatened to actually shut down parts of New York City that aren't compliant with these new social distancing rules. Do you think that kind of warning will influence people's behavior? I mean, is it possible we could go back to a lockdown, as Beijing is now going back to a partial lockdown right now?
You know, I hope that it wouldn't get to that point because, again, you know, we've come a long way in terms of reducing the ongoing transmission of infections, and what it would take to keep that number down is actually something that's very easy in the big scheme of things. And honestly, it may be inevitable that we would have to revert back to a strict stay-at-home policy once again, but my hope is that we won't have to come to that.
Okay, we have a question here from one of our New Economy community members, Lara Retta. She's the Associate Chair for the Department of Emergency Medicine at North Shore University Hospital in Manhasset, and she asks, in the event of a resurgence in the number of cases, how can public officials help hospitals mitigate drug and equipment shortages?
This has been an issue that has played out in public for the healthcare delivery system and for public health. And the reality is that to the degree that healthcare delivery hospitals and governments can work together to ensure not only the supply chain, but visibility into the supply of, for example, personal protective equipment across hospitals so that we can divert supplies as needed, will be, I think, the best way to ensure that when and if we do have a second wave, all hospitals, regardless of whether they are public hospitals or private hospitals, will have the necessary equipment that they need. In this past aspect of the response, we as a city were able, in collaboration with the state and our healthcare partners, able to provide equipment. But the reality is that it was harder than it needed to be. And I think there have been some lessons learned, hard lessons learned, in terms of what it means to really partner.
Just a follow-up question to Lara's question. Is there any evidence that these anti-racism demonstrations in New York and other parts of the US may have triggered a new spike in infections?
There's a couple of things on that. First and foremost is we have a number of different data streams that we monitor on a daily basis, whether or not there are outdoor protests, to determine whether we're seeing upticks in cases that would give us concerns about a COVID resurgence. Certainly, when people congregate, there is always that risk of ongoing transmission. But the reality is that when people are outdoors, the risk goes down pretty significantly. On top of that, if people are using face coverings, again, it goes down even more. And then lastly, maintaining that social distancing is what's going to help. Thus far, we've been monitoring those data systems, and we haven't yet seen any upticks or even a hint of an uptick. But again, it really reinforces the need for New Yorkers to continue to use face coverings, whether they are protesters or whether they are police at these demonstrations.
So I want to talk about the COVID map of New York, which you have on your website. And it shows shockingly that COVID-19 has disproportionately affected the poorer areas of New York, those areas with large African-American communities, other minority communities, the Bronx, Staten Island, parts of Queens. And by contrast, wealthy Manhattan has been relatively unaffected. In your public statements, you've been very clear about drawing a direct line between inequality, racism, and public health. How has COVID-19 exacerbated these problems?
Those maps, they say maps say more than 1,000 words, and I think those maps are a very clear indication to the degree to which systemic structural racism has played out, not in the immediate period only, but for generations in this country. And certainly New York City is one of those places where we have immense inequalities, right? There are chasms in terms of life expectancy in less than a 20-mile distance, in less than a 5-mile distance. And so the reality is that this extreme event, a pandemic with a virus that's so vicious, has really just ripped the scab off of the structural racism and generations of disinvestment in a way that's played out not only in terms of inequities and access to testing and access to stable housing to be able to separate equally and safely, but the way in which deaths have played out. And it's something that we as a public health entity try to address as quickly as possible. But the reality is that there are still such entrenched inequities that this kind of event, I think, is going to take a significant amount of time, resources, and energies to undo and to recover from.
So you grew up actually in the South Bronx. How has that shaped your views on this issue?
Yeah, I spent my early childhood in the public housing developments in the South Bronx, and I think it gave me a very intimate experience and relation to what it means to live in housing that may not necessarily be the most conducive to safely isolating during a pandemic, to the challenges of having parents who had to work more than one job each at the same time and not having the luxury to work from home rather, and having to commute to jobs that barely help them keep their heads above water. So I think all of that in combination with my experience as a pediatrician in inner city DC and seeing those same issues played out 30 years later, and now 20 years later nothing has changed. There are some folks who I think would be understandably demoralized by that, but I'm an eternal optimist, and I have really a strong sense of what it takes to bring people together and to work off of hope rather than working off of despair. So, it's been a very challenging time, but I think that there has been a groundswell of outrage of the way in which racism has played out on a very sort of huge scale, and with the acuity and the lives on the line. I think I can't see a situation where we don't act in the recovery period to address those inequities. It would be immoral.
So you talk about outrage. Much of the outrage in the Black Lives Matter protests have been directed at the police force. Do you think that police methods in the United States have become a public health issue?
So I think broadly speaking, racism is a public health crisis. And I would add that, it's not just about police, it's about all of the structures that are a part of our society that contribute to the structural violence against Black and brown people. It's our housing policy, it's our educational policy, it's our economic policies that work to keep communities in a situation that makes it hard for them to recover or even to respond to seismic events like COVID-19. Now, certainly, the police is where it gets played out in the most dramatic fashion. And I think that it is symptomatic of the underlying issues that are unfortunately pervasive in a lot of our country. And so, to the extent that Black Lives Matter, to the extent that the COVID-19 response are really sort of laying these issues bare and forcing us to react, I think in the long run will be a good thing. My hope is that this will be an opportunity for us as a country to heal. But, we have to be realistic that it's going to take a while and it's going to be painful, very painful.
Last question. Do you support the demands of protesters to defund the police to the extent that it might remove from law enforcement functions, those functions that might be better performed by social workers and public health authorities like drug addiction, mental health, and homelessness?
I think, these calls are an opportunity for us to think about why is it that we as a country have thought that it was a good idea to have police in our schools? Why is it that we as a country thought it was a good idea to have police play the role of social workers when it comes to drug policy, when it comes to housing? I think certainly We are at a moment in history where we have to interrogate what we previously took for granted as the norm, and to collectively reimagine what it means to rebuild our country.
Dr. Barbot, thank you for being with us. It's been a real privilege.
Thank you.
That was the Commissioner of Health of the City of New York, Dr. Oxiris Barbot. Now let's meet our panel today. It's my pleasure to introduce our three guests. First of all, Dr. Preetha Reddy. Dr. Reddy is the Vice Chairperson of Apollo Hospitals, the largest hospital group in India. She's also the President of Nat Health, Healthcare Federation of India, working closely with the government of India to advance progressive policy decisions in healthcare. Dr. Reddy, thank you for joining us.
Namaste.
Gregory Rockson. Gregory is the co-founder and CEO of mPharma, a technology-driven inventory and retail pharmacy operator, managing a network of over 400 pharmacies with operations across 5 countries in Africa: Nigeria, Kenya, Ghana, Zambia, and Zimbabwe. Welcome to the program, Gregory.
It's great to be here.
And finally, Mike Wells. Mike is the Group Chief Executive of Prudential Plc, a London-based multinational life insurance and financial services company. Under Mike's leadership, Prudential has developed Pulse, a digital health platform for Asia, which combines AI, symptom checking, telemedicine, and wellness advice. Welcome to the program, Mike.
Thanks, Andy.
So, Dr. Reddy, I want to start with you. Many in New York have criticized the authorities for locking down too late. In contrast, the critique within India of the government is that it locked down too early and is now reopening the country just as COVID cases are starting to soar. What are you seeing right now on the ground in Mumbai and in India more generally?
First of all, I live in the south in Chennai, but we track Mumbai and Delhi very closely because we have institutions there. On the question of the lockdown, it's very clear that if we had not locked down, we would have hit 1 million cases by now. The fact that there was an early lockdown mitigated the amount of damage which possibly could have happened. But because the country is so large and the population is very dense in certain urban towns and cities, we need to go back and do it, all over again, because this is a learning. It's a global learning for everybody. And it did show, there was data to prove, there were epidemiologists and scientists working on it, that the lockdown really helped. It was lifted because, then people were jobless and we had other issues. But to bring it back again, I think is absolutely necessary, because community spread is there to some extent. And if we have to curtail that, then a second lockdown is something which is required.
So I want to bring up a chart which shows the number of new cases reported in India. Obviously, it's climbing steeply. Do you worry that the hospital system, including your own hospital system, could end up being overwhelmed by COVID cases?
Well, the numbers going up is definitely a concern. But then if we look at the numbers who have, successfully overcome the disease, that's quite a large number. Somewhere in the future, we are hoping that the curve would flatten. The healthcare systems do have to gear up. I don't think whether it's a developed economy or an underdeveloped like ours, anybody could cope with this kind of a pandemic. It took humanity completely by surprise, and there's no two ways about it. But I think policymakers, scientists, medical researchers, and healthcare workers like all of us are to see what can we do to cope. I come from a hospital organization. We have 10,000 workers at any given time, frontline workers, working with patients with COVID. We manage over 1,000 beds, and we help with another 2,000 beds. So I think the sector, the private sector and the public sector has come together. The good thing is that the large corporates in the country who, with a completely philanthropic mindset have quickly swung into action, whether it's manufacturing of ventilators or PPEs or quickly, developing spaces which can take care of a couple thousand COVID-struck patients. Everything is happening in our country. So I think the country has come together to fight this pandemic, and that is really our success story.
Gregory, the COVID map of New York tells a simple but incredibly powerful and poignant story about grotesque inequalities. What does the COVID map of Africa tell us about inequality on the continent? Ghana, where you said has had relatively few cases, been relatively successful in combating COVID-19, although I see your healthcare minister has recently tested positive. Whereas, for instance, in Africa, where you have high levels of HIV, it's really cut a much, much deeper swath within the country.
Yeah, I think we are still in the early days of figuring out the disease curve in Africa. But at the start of the pandemic, there were two very big issues in terms of access to health commodities. I can give a story of us trying to secure test kits. And on the day we were supposed to make payment for the test kit, a European country sent a military plane to China to pick up all the test kits. So the challenge has been that in this sort of global scramble for healthcare commodities, Africa has unfortunately not been prioritized. So we look at a continent of over 1 billion people, and we are not even doing more than 10 million tests as of today. So we need to rethink how there can be an even access to the healthcare commodities that are needed to be able to drive the type of outcomes that we are looking at. Secondly, at the country level, there's a bigger issue of inequality around urban slums versus the urban locations that are well-to-do, similar to what you see in New York. And I believe that one of the things that we need to really think about is how do we reimagine the type of cities that we are building in this new economy, right? We are looking at urbanization in Africa going from 15% in the 1960 to about 60% in 2050. But unfortunately, we will be creating unlivable cities, pretty much creating urban slums. So once you create urban slums, as we've seen with this pandemic being a crowd disease, the question is, how do you respond when you cannot actually social distance because you are all living in areas that you cannot move around? So the inequality is at the global level with how you get health commodities, but at the country level, how do you redesign the cities that we live in to be able to increase access to care?
Mike, you run a global company. Talk us through the global map of COVID-19. What does it tell us about global inequality? I mean, it's really remarkable the way that East Asia, for instance, these economies have held up so well amid COVID-19. Many of them are actually going to grow this year, not by much, but they're still going to grow. And in these countries, you see very robust healthcare systems. You have epidemic preparedness. You have high levels of trust in government, strong institutional delivery to institutional capacity, and so on. And yet, Latin Africa, as we've heard, is a very much mixed picture. Latin America is a disaster or a disaster in the making. Brazil, Mexico, Peru, and so on. Is there a danger that COVID-19 is going to exacerbate global healthcare inequalities?
So I think to frame our perspective, my perspective is we're one of the largest healthcare providers in Asia, in pretty much every market in Asia. We have a presence and are successful in that industry. So we're not in the U.S. health provision or Europe. So let me focus on sort of the Asian experience we've had. So we started with China. So the early, COVID was an issue last year, and there's been a lot of learning with that. Culturally as well as economically, there's differences. So if you think of Hong Kong, you have about 1,000, the last number was 1,085 cases in Hong Kong, 4 deaths, which is, the 4 are tragic, but a shockingly low number given the amount of cross-border travel from mainland China and the early exposure they had to people who might have been exposed to the illness. What you did see on the ground, though, in the beginning of the year was culturally, before there was government policy, a caution around health. People wear masks in Asia as a courtesy to others when they're sick. It's not to protect themselves. I get North American friends that always say, I'm wearing a mask now and they think it's a shield. It's actually generally for someone else that you wear that. There's there's muscle memory from SARS and the bird flu and things where cultures understand to take health issues seriously early. And then the other thing I think you in the balance of economies, your point earlier, so Asia started with growth where, Europe would have started the year probably with flat or negative growth. And so, you have more to work with economically, but it's the same policy decisions for these leaders. They're trading off, income for health and often financial inclusion and health inclusion. And Singapore has been very dramatic. I think Singapore is often referred to as the Switzerland of Asia, which would imply a very serious focus on their economy. And they do, and it's very well developed. But you see they're one of the most conservative, one of the most healthcare centric of the governments in Asia. And they're most cautious with their populace health. Those are policies. That's why people trust the government. That's why they're supportive. They see those trade-offs being made, and there's an alignment with, I think, the social policy and the people executing, and the populations are smaller. And one of the dynamics that's real is there's borders. So they're defining travel, inter-Asia, where if you look at the U.S., interstate travel and the individual policies in states and cities and things were completely they were unaligned. They were, New Yorkers weren't welcome in Florida, as you saw, and the license plates from New York were, scarlet letter for a while on the East Coast, right? Those sorts of policies are addressed at a more national level in Asia, and I just think there's a cultural understanding of illnesses that's again more developed from having dealt with other challenges.
Gregory, go back to your story. You talked about this scramble for pharmaceuticals as a pandemic started spreading around the world. How big a threat? People talk about medical nationalism and vaccine nationalism. How big a threat is this to Africa? Do you think? And what are the answers to this problem? Is it more manufacturing in Africa? What in your business would make you more resilient to this kind of threat?
Yeah, I think it's one of the biggest threats we actually face right now. When you actually look at manufacturing across the continent, it's actually declined from about 15% as a sector in 1995 to less than 10% this decade. So when we were hit by the pandemic, like getting stuff like hand sanitizers was a problem. Right. So I think we've realized that we can no longer just rely on the generosity of the world. We need to actually, as a continent, think through how we build a healthcare manufacturing ecosystem that can actually enable us to build self-reliance. And, recently we created the Africa Free Trade Continental Agreement, which we hope will help Africa as a continent negotiate better and trade among itself much freely. I think the next step that we need to take is identify specific regions that can become healthcare development manufacturing centers. Like West Africa can become the pharmaceutical manufacturing hub for Africa. Southern Africa can be the digital health ecosystem for Africa. And then by being able to create these regional hubs, we would be able to then respond appropriately and trade within ourselves without having to rely on the generosity of the world, as we saw currently failing us when we needed to get the critical supplies to respond to the pandemic.
Dr. Reddy, one of the abiding images from India coming out of this pandemic is these millions of unemployed day laborers and their families flooding out of urban slums, going back to their villages, carrying COVID in many cases with them. Does this pandemic, do you think, within India create a whole new social divide?
I don't think it will create a social divide. And let me say this, because a lot of them were day laborers. And when they found that they were not getting their daily wages, then the thought of going back home, because they come from rural India and they would probably be able to get a square meal if they reach their homes. And 40 million is the kind of number which we have of the kind of migrant population in a country of 1.3 billion people. 7.5 million were the people who tried to go back and move back. And there were many measures which were put into place, but this was the most unimaginable, unprecedented, unparalleled migration ever in our history. Even when between India and Pakistan post-war, when people migrated, it was not these kind of numbers. So I think for us, it was definitely a huge shock, but I must say that the policymakers swung into action. And a lot of benefits were given to them, and a lot of benefits are also in place. We have to see how it pans out. But we're hearing that a lot of the so-called migrant labor now want to come back because, they know that they have some kind of a job security from where they moved. So it was a panic which was created. It was terribly unfortunate, but we think that as we rebuild our nation, as construction work goes on, as manufacturing increases over maybe in the next 24 months, the migrant labor will come back, but the policymakers will have to put certain safeguards in place so that this never happens to them. But I'm a very positive thinker. We've lived in India and we believe in philosophy, we believe in the power of humanity. And I don't think this is going to create a cultural divide or a racist issue, because everybody tries to help each other and there's no radical divide between them.
Okay, I want to bring in a first audience question. This one is from Carlos Garcia. He is a senior consultant at Advanced Consultores in Mexico. Carlos asks this: what health strategies do you consider to be necessary for better control of pandemic events like COVID-19 in the future? Mike, do you want to have a go at that one?
Yeah, I think the front end of this, right? So you brought up income being one of the issues, but general wellness, and particularly when you look at the deaths related to COVID, the presence of chronic illness, someone's general sense of well-being before they're infected is a key determinant in who lives and who dies from the illness. So doing more on the front end of this and things you can do to improve people's health awareness and fitness and condition, things that are on the preventative side are key. There's also an information sharing piece in this that gets into which part of medical data on an individual do governments see and privacy, but there's a technology piece in this that you're seeing playing out where you mentioned the Pulse platform we rolled out, for example, has a symptom checking capability. In one sense, it helps the hospitals with it's sort of a individual triage. It's also, though, for an individual, if someone works a long way from a hospital, which we get in a lot of the rural areas, which again are hit hard by this virus, do they take a day off work to go to a hospital? These sorts of decisions, there are tools in the marketplace that can improve a consumer at any level of incomes, access to better information, access to better personal care. I'll give you a couple of quick ones. We have one capability in it that's dengue fever predictive mapping, right? That tells you you're in an area that's you potentially could get the fever. We also have on the lighter side a wrinkle index that tells you from a selfie how you're doing health-wise and if you're taking care of yourself. Well, there's a bit of gamification in that to get people to use frequently and regularly a health app if they don't feel well. So they get linked to telemed, so they get linked to a hospital. So you get to these sick people earlier. And I think that allows the care providers to do their job better, faster.
So we're going to get back to telemedicine a bit later. But to Mike's point about general health and wellness, one of the disastrous side effects of COVID-19 is that people are foregoing regular medical treatment. They're just not going to hospitals unless they've have symptoms of COVID-19. They're afraid of going to see a doctor. Dr. Reddy, how is that playing out in your hospital network in India?
So we are seeing, of late, there are more admissions into the ER because people are coming now with heart attacks, which was expected. With the lockdown, nobody ventured out, and then they realized that they need interventions. I think the emergencies are definitely on the rise, which is awesome. Also, India has the largest number of diabetes in the world. Globally, we're a diabetic population. And unless they know to take care of themselves, unless they have, preventive maintenance, preventive checkups, I think we're heading for another disaster. And we all know and understand that the NCDs, cancer, hypertension, diabetes are all on the rise. It's showing a 30% increase globally. We've seen a new problem, which is mental health. Mental health suddenly has another problem, and I think policymakers, governments, nations, citizens have to deal with that. And there's a very strange problem globally is that on one side we find malnutrition, and on the other side we find obesity, and obesity again leads to all these diseases. So I think there's a dichotomy here, and how do we come up with answers to educate people, to take the point of care to literally, to their palms, like Mike and his company is doing? How do we really to get the point of care to people so quickly that the intervention can make a huge difference? I think all these are what a better world and a new economy is going to be all about.
Gregory, what are you seeing in the pharmacy business in Africa? I mean, many poor countries in Africa have suspended their vaccine programs. There's been spikes in cases of diseases like cholera, diphtheria, measles. Are you worried about other diseases surging as the focus is on COVID-19?
Yeah, and we've learned that the hard way with Ebola, that more people actually died from malaria during the Ebola crisis than they actually died from Ebola, simply because of the suspension of many healthcare services, as well as also the entire focus around healthcare delivery in the countries that were hard hit by Ebola, going towards controlling and treating that disease. I think one of the bright things that has come out of this crisis is reinforcing the role the pharmacy plays in the community, right? So even though many people have not gone to hospitals because of the fear of contracting COVID, we've actually seen an increase in the number of people going to the pharmacy because they see that as a much safer place to get the care that they need. And also you get to meet a pharmacist who you get a free consultation from, and then you only have to pay for your medicine. So I think as the pharmacy and the pharmacist is the closest person, healthcare worker to most communities in Africa, the question becomes, how do we imagine the pharmacy just from being a drug seller to actually becoming the primary contact for primary care in Africa, since you have more pharmacies dotted around most urban areas and even urban slums and rural areas compared to clinics and hospitals.
So let's talk about telemedicine. When people talk about rebuilding global public health systems post-COVID-19, there's this huge focus on that area. I want to show you a pie chart which shows just how quickly the public has moved to embrace the technology. 76% of consumers surveyed by McKinsey are interested in using telemedicine. Let me start by injecting perhaps a slight note of skepticism here. In this pandemic, the methods of disease, successful methods of disease control have been decidedly low tech. Hand washing, social distancing, quarantine, of course, a medieval practice. Do you think we're in danger of hyping the potential of AI, robotics, genomics, and some of these other supposedly transformational technologies? Mike, could we perhaps start with you?
No, I mean, the short answer to your challenge is no. I mean, I think medicine and the delivery of healthcare has always evolved. And I think the starting, you can't start with a bias that a US or European model is the correct model for all economies going further. Most economies can't afford it. I mean, and it isn't necessarily the best path, as we all know. And just your first speaker highlighted some of the challenges in it and its fairness of delivery. So I think AI can replicate the most basic questions that a physician asks you, and it can do it flawlessly over and over again, and it can give those answers to the doctor in a very efficient way. So if nothing else, it's very good at an interview. It's scalable. The issues on health, let's go back to COVID for a second, but all notice the rural has less income, to your earlier point, and it has less access, as Greg said, to clinics and doctors and hospitals. So you need solutions that can push what are urban care into rural areas, to older people, to things at scale. And technology is a very, very good way to do that. The downside, the telemed model is very popular with our younger, it's very popular across Asia. We've been advocates of this, as you know, for a while. It's also very popular with young consumers because they actually think, a consultation, for example, with a doctor in this sort of format is a completely rational way to have an advice conversation. The challenges with it will be data. We can't move data from cross border and your personal data and the protection of it. And then the other is licensing. You're not going to see a Mumbai doctor center servicing other markets because the medical licenses may or may not carry across those jurisdictions. So globally, we've got a long way to go to scale it, but the service is very effective. It fills gaps in numerous countries, rather geographic or income or health capacity challenges, and I think it's a tremendous technology.
Okay, let's see what our audience think. Let's go to our first audience poll. And here's the question: how willing would you be to adopt telemedicine as an alternative to primary care? The options here: I'm already using telemedicine for primary care. I haven't used it yet, but plan to in the future. I'd be willing to try it, but I don't think it's a good substitute for a doctor's visit. And final option: I'm not interested in telemedicine. I prefer in-person doctor visits. Dr. Reddy, while we're waiting for the audience to answer that, to submit their answers, let me ask you, does online consultation lead to medical outsourcing? What difference does it make to me whether my doctor is sitting in New York or Mumbai if we're talking online? Are you going to see a boost to your business in the Apollo hospitals from telemedicine linked to Europe, linked to the United States, and indeed all parts of the world?
We do. We were the first telemedicine providers in part of the world, and it was actually Bill Clinton who inaugurated our program from a small village in Andhra Pradesh to a city. Today, we do about 2,000 telemedicine consults every day. And, the highest point in India, the borders where we fight to the most rural villages, telemedicine is practiced. It's growing, and every year it's showing about a 20-30% increase. So I think telemedicine is here. It will come in many avatars. The borders between countries will at some point not exist. And at that time you will see, because there's already radiology, and radiologists are reporting data, they're reporting their slides. But in pathology, slides are being reported. So I think it's already happening. The cross-border active telemedicine consults will happen, but I think the doctors are going to have degrees in 2 countries. At least they have to have some kind of credentialing before they're able to prescribe for a patient, whether in the UK or in the US. There has to be some kind of certification, and when that happens, like Mike said, I see it happening. There are already smaller outfits who are doing purely telemedicine. So in a way, it's like outsourcing. And that is bound to grow. And as a business, as a way for future, as something in the new economy, we see that as a growth path.
So let's look at the result of this poll. Quite some skepticism. I'd be willing. 43% would be willing to try it, but don't think it's a good substitute for a doctor's visit. No, very few, 4%, are not interested in it at all. Gregory, half the planet doesn't have access to the internet, including hundreds of millions in Africa. Is there a danger that telemedicine might actually widen the digital divide?
Exactly. I am less concerned about the underlying technology because I think, it would continue to get better and AI models will continue to get stronger in this respect. I think much more important is on the technology divide question. How do you actually increase access to broadband to be able to fully embrace the full capacity and models that telemedicine can bring, not just to those that have smartphones and other devices that they can use to access these tools. Also in Africa, we find ourselves having some of the most expensive costs for internet data, right? So the more expensive these data bundles are, the less people can actually afford to pay for it and to use. And then finally, telemedicine at this most rudimentary level still requires a health worker to be behind that technology, and we have fewer health workers as it is even to treat people going into the health hospitals and healthcare facilities. So how do we actually also improve our healthcare workforce that we can actually then use some of that to enable this new channel that people can access for care?
So, Dr. Reddy, to Gregory's point, I mean, India is building out a national broadband network. I mean, perhaps more slowly, more fitfully than its architects planned, but nevertheless, it's a visionary undertaking. Is this finally the answer to massive unmet demand in India for medical services? Indeed, could it help to rejuvenate the entire Indian economy?
So our internet and cell phone penetration is actually one of the quickest and the largest globally. People using cellular phones have adopted to that technology much faster than anywhere else in the world. So with that comes services which are added on, whether it's banking, whether, now it's even education. And definitely healthcare services happen. It's already happening because, those who have access and those who can understand what they can get out of it can definitely ask questions. They can access emergency response systems in certain states. So we will see the penetration of medicine definitely happening, and it will increase by at least 40 to 50% is what is predicted. But the question here is, do we have enough manpower for the needs? And that is probably the largest problem globally. And much as we have technology, much as we have intelligent systems to answer that, we still need frontline healthcare workers. And globally, there's a shortage of doctors, shortage of nurses, shortage of technicians, allied health workers. And I don't think, anywhere have we thought through it enough, nor have we trained or skilled or produced manpower to answer these needs. So, telemedicine will take care of that much of people's unmet needs, but this is a bigger problem, the shortage of skilled manpower, and I think that need has to be addressed quicker and much faster.
So let's talk about public-private partnerships, which I think everybody agrees is going to be a key to rebuilding global public healthcare systems all over the world. We're seeing smart entrepreneurs like Gregory. They're coming up with digital healthcare solutions, yet all too often governments fail to get behind these innovations by providing funding, regulatory support, enabling infrastructure, and so on. What's the answer? How do you get public-private partnerships that actually work? Maybe Gregory, you could have a go at this, and perhaps Mike and Dr. Reddy can too.
Sure, thank you. One thing that was very shocking for me with COVID was how, we could finally just open our wallets. The governments could finally open their wallets and just, throw as much money, paying for vaccines that are yet to be produced. And I just wondered, what if we had made these investments before now? Right? Unfortunately for most governments, they tend to take a very reactive approach to crisis instead of taking a much more long-term approach to thinking about healthcare development. And most people see health as a cost center, not as an investment center that they need to proactively drive. So I think, most African governments must start thinking about healthcare investments like venture capitalists, right? It may not pay out right now, but if it pays out, it's going to be a much bigger outcome than what you expect. In Ghana, more practically, for example, the Ghana Investment Promotion Center, which is the government agency's arm, has been very proactive with the CEO working very closely with me to say, how do we streamline the regulations that we have in this country to enable us to tap into this newfound opportunity that public health can bring to the country. And we hope that we can see more government agencies moving from thinking as civil servants and bureaucrats to actually wearing an investment banker's hat to thinking about investing in healthcare as an investment opportunity than a cost center.
We can't really talk about digital healthcare without reference to privacy issues, and COVID-19 has given rise to the growth of what some people call, the biosurveillance state, particularly in East Asia, where you have governments that require their citizens to install apps in their phones that monitor their movements and who they're mixing with and so on. Mike, is this a temporary phenomenon, do you think, or is this kind of pervasive surveillance going to become increasingly a part of global public health? And what are the implications for personal privacy?
Well, I think, Andy, there's so the data, for example, we collect on the symptoms checker, which would be an artificial intelligence doctor, say in the UK. That is encrypted. That's client based. But again, different jurisdictions have different rules of who owns your health data. So in some cases, it's the health provider. In some cases, it's the individual. It's not those sorts of public policy issues haven't really been aligned yet. So start with that. So there's a different definition of whose data it is based on the market you're in. Then to your point on proximity and some of the other health apps, talking to friends in China, that's probably one of the most advanced economies in terms of integrating digital openness to tools like that, right? But it's consumer supported as well as policy supported. So friends in Beijing if there's a proximity app that tells you and I are low risk and we get a green or yellow or a red going to a restaurant, they're fine with that because they see it as a tool that helps them stay healthier. I've done the lockdown with four people in their 20s. Two of my wife's and my biological sons, and then two young people have lived with us for a decade that might as well be family. And 20-year-olds have a very different view of data privacy and what trade-off they're willing to make for luxury and convenience on their devices than I do. And I think they see it as a currency. They're not naive to what data is being used, not used, but they see convenience, and benefit coming from those trades. So you're going to see different geographic executions of it based on just culture. There is absolute benefit to it, and then to your point, there is the ability, like any other technology, for rather private or policymakers to abuse that technology. Let's not take out a tech firm or a large evil insurance company from the list of people who could misuse information, right? There's whoever has the data has a responsibility to handle it responsibly, protect it, not use it for anything that isn't in the mutual benefit of the participants. And that doesn't necessarily just mean governments.
Okay, let's bring up a second audience poll for the audience's take on this. How much would you trust government with your data in the interest of public health? 0, that's an invasion of privacy. Somewhat, if I could be assured my data would be kept anonymous and secure. I trust my government with my information if it helps manage the spread of COVID-19. As we wait for the results of that poll, let's go to an audience question on data and health from Stephen Donaldson, who's the principal and CEO at Radiant Brands in the United States. Stephen asks, how can we better manage getting the right data on who is infected, who has already had the virus, and use online analytics and mapping to give the policy and government decision makers the right real-time data to direct resources and manage reopening? Dr. Reddy, do you have thoughts on that? How can we better manage getting the right data on who's infected to help with this reopening?
So we have been working with the state governments. You know, I'm sure it's there in New York City or wherever else, and they have a real-time war room, and I think the data is managed very well. They are literally tracking almost every citizen, and the only problem here is that the number of people being tested, and that we're a bit unsure of, but those who are tested, I think the data is being managed very well, including, you know, how they do the hospitalization. Going forward, if the problem becomes so huge that, you know, there's not enough resources to track the data, is a problem. But I think as of today, the data has been tracked and managed really well.
So 23% of our audience trust the government with their information. Quite a skeptical response. 70% somewhat only if I could be assured of my data would be kept. Surprisingly, only 7% have really acute fears of invasion of privacy. We're running out of time. One last question from before we wrap up. Dr. Ramesh Wadhwani, the CEO of Sites Systems International in the US, asks Dr. Reddy, what protocol will the pharmaceutical industry follow to distribute a vaccine once it's ready? If all countries would want to be the first in line, what advice would you give to Western countries to have patience?
So I think, you know, this is such a vital question, and it's being debated globally in multiple fora, that humanity has rights to vaccines, and it should not be the priority of, you know, whichever nation has had the money and the resources to develop it. And there has to be, you know, equality with the way vaccines are developed, because there is going to be a huge rush for it. People are afraid. People want the vaccines fast. Anybody would want it. The problem is it should not go to people and nations who can afford the vaccine, and then the others are left high and dry till we find, you know, less expensive or cheaper, or, you know, many options where we can mass produce it. So I think it's a huge concern. There is no, you know, right answer or a wrong answer, but I think we need to, all the global leaders have to come together and say that wherever it's needed most, it has to be given, and I'm hoping it will happen.
Gregory, sorry, a very quick one for you, Gregory, from Meg Maggio, director of Pekin Fine Arts Gallery in China. She asked, how dependent are you on Chinese supply chains for medicine and medical supplies?
We are very dependent on China and India, and we need to think of ways to break that dependency.
We're going to have to leave it there. We're out of time. Dr. Preetha Reddy, Gregory Rockson, Mike Wells, thank you again for joining us today. We're grateful for your participation and perspective. I'd also like to extend my thanks to Dr. Oxiris Barbot for taking the time to join our conversation, and to our audience both within and beyond the Bloomberg New Economy community. Thanks for joining us. We invite you to our next conversation 2 weeks from today, called Grounded, the Future of Travel, focused on the challenge of rebuilding the global hospitality sector in the wake of COVID-19. That's on Tuesday, June the 30th. follow the conversation with @NewEconForum on Twitter or like us on Facebook. And to learn more about other upcoming events, please visit our website at neweconomyforum.com. Thank you and stay well.